So let's talk about BiPAP. Okay, so the first BiPAP we're gonna start historically. The BiPAP was basically a machine that a box that the only thing it does, it provides one limb to the patient, and it powers the flow, and it gives the patient through the corrugated tubing and the mask. It gives the patient a certain flow to increase the pressure. And there was no oxygen actually that the BiPAP machine itself can concentrate. So you don't know the concentration of oxygen. There was something called bleed-in oxygen. They call it like this, respiratory rate, which comes from the wall or from the tank, the usual, and it just bleeds in here. It's like almost like a nasal cannula tubing that comes up and just goes into that here. It joins the tubing, the corrugated tubing. So you turn the patient at 2, 4 liters, something like that. You know the liters that you're giving the patient, but you don't know the FiO2 that you're giving the patient, right? So that's the original bypass, which is like not too, that was the one in use in hospitals 20 years ago, up to 20 years and maybe a little bit more. You know, actually more than that. You know, up to 15 years ago, these things existed in the hospital, and that was the main thing. Of course, things started to get better quickly. Now, the bleed-in oxygen is a scam, because if you can imagine what the FiO2 here for the patient, the bleed-in oxygen, let's say 2 liter nasal cannula, right? The flow here, the least flow probably is 30 to 40 liters. You know, that's the least, maybe 30 liters flow. Usually 40 or more. But let's assume it's 30 liters of flow. So you're giving 30 liter per minute flow, and then 2 of room air, and then 2 of them are 100% oxygen. What do you think we're raising the FiO2 by? From 21% to 22% maybe? That's it. That's the only thing this bleed-in oxygen does. It's just placebo-wise, it actually makes the COPD patients like it, because I'm always on 4 liter nasal cannula. Then when I go on BiPAP, I'm going to continue to be on 4 liter BiPAP, which is nothing. So the bleed-in oxygen is not useful. Thank God, the main reason we use BiPAP is COPD, which people don't usually need oxygen, and you know, sleep apnea, which also most of the time they just need pressure. Now the BiPAP after that started to get better, and we started seeing BiPAPs that you can titrate the oxygen, and you can somehow see what's going on with the patient. You know, you can see what the tidal volume, for example, that the patient is getting. Traditionally, BiPAP, by the way, gives you inspiratory tidal volume. So when you see tidal volume in the BiPAP, the nurses or somebody's coming to you and saying, the tidal volume is low on the vent. Guaranteed 100% of the time, what they mean is the expiratory tidal volume. But if somebody say the tidal volume on the BiPAP is low or high or whatever, they mean the inspiratory tidal volume. And that sometimes freak people out, because they say, the tidal volume is 1200 cc's. That's not according to, that's not in accord with the protective lung strategy. What is the protective lung strategy has to do with this? Protective lung strategy is for ARDS, adequate lung injury. This is for COPD and pneumonia and stuff like that. They're not the same patients. And also, you're not forcing the pressure inside the patient. If there's a lot of resistance inside the lung, the air is going to go somewhere else. It's going to come out of the mask. You know, it's going to leak. It's going to go in the esophagus. It's going to go anywhere. It's going to puff the cheeks. Whatever. But that air is not going to go and injure the lung because it's 1200 cc's. You got to be smart about it. It's crazy. Huh? So that's why I'm trying to say it is the inspiratory tidal volume. So don't worry about it. The patient actual tidal volume is not what you're seeing, because things are leaking and all over the place. So the BiPAP, usually the main things are like nasal BiPAP or full face BiPAP. And nasal BiPAP has no use in the ICU because of the pressure. You know, you have people who are having pneumonia or something like this, lung disease, so they have a lot of resistance inside. If you give him only nasal BiPAP, what is the path of least resistance? The path of least resistance is the mouth. The air is going to just come out through the mouth. But if you give him, you have to give him people who are sick like this full phase BiPAP. The nasal BiPAP has a role in sleep apnea, right? Because it just opens the airway, it just keeps, pushes the tongue away from the posterior airway. Now there's a lot of other modifications of these types of BiPAP. At home, they now have the pillow BiPAP, which is something better than nothing. It's usually, if you have an element of sleep apnea, which a lot of people have, you have these two prongs that go into your nose and they blow up, become like a balloon, so it's like sealed in the nose and just keep on pressuring. It still can come out of the mouth, but it's better than nothing. They use it at home and people like it. They also have a mask that's like the best of the two worlds, right? Instead of having a mask that pushes on your nose and causes a pressure ulcer there, they have a mask that ends like this, under the nose, right? So it just goes under the nose like this with the holes of the mask. There's two holes in the mask actually that also open to the nose. So you have the full thing goes through the mouth, but also the nose is being ventilated without pressure on the top of the nose. When we had that mask, we used to use it just in conjunction with the other mask. So one time we go like this, one time we go like this, so we can exchange it a little bit. So not all the time you have pressure on the bridge of the nose. There's also the full face BiPAP that goes like the real full face BiPAP, right? And it goes around like this, and that actually removes the pressure off the nose. But the whole patient is like in the, and it fits better. There's much less leaks, and the patients like it for some reason. It just needs a lot of eye lubricants and stuff like that. And if you give Atrovent, neb, what's going to happen? The pupils will dilate and the vision will be blurry. Then we go to CAT scan. Now the BiPAP that we have here now, and all over the place actually, it became the most famous BiPAP now. By the way, the expiratory tidal volume on the vent, when you see that, you can actually dial also, or you can find on the vent what is the inspiratory tidal volume. So if you're told about the tidal volume in the vent and you want to see what the inspiratory, you can put inspiratory and expiratory next to each other. For the BiPAP, you don't have that option. You have inspiratory only. So the BiPAP now is the V60 that we have, the Philips V60. That's actually a great BiPAP. It's a great advance in BiPAP, and I think since the invention and the commercialization of this BiPAP, I think the statement that says that the patient did not tolerate the BiPAP should actually disappear from our lingo. There's no reason now, and there's better BiPAPs than this, by the way. There's no reason that you will actually need that the patient cannot tolerate the BiPAP. You can do everything to make the patient tolerate the BiPAP. There's so many bells and whistles and stuff, and we will talk about it. Now let's just talk about something that is very important. These are the settings of the BiPAP here, and I'm gonna so there's vent BiPAP. So this is something that is kind of confusing, but we just have to pass that hurdle first before we move on to troubleshooting. So there is vent BiPAP and there is machine BiPAP. The vent BiPAP is that the ventilator can be used as BiPAP. Most ventilators can be used, most new ventilators can be used as BiPAP. The old Draeger that you see in most hospitals and on TV, for some reason, there's all over the COVID epidemic, everything was old Draeger. That Draeger doesn't, the 860 Draeger doesn't do BiPAP. But anyway, the vent BiPAP, it has 3 modes in every vent, right? Or at least in the Vela that we use here. One of them is called NPPV Cpap pressure support. This is a long name. NPPV SIMV and NPPV AC. Right? The machine BiPAP, you have options of ST, spontaneous time, and that's the BiPAP that most people use. Cpap, pressure control, PCV, and AVAPs. That's the Philips V60. Okay? So the MPPV, MPPV is like non-invasive positive airway pressure. Or positive pulmonary ventilation. So anyway, so that means that when you see this word before, that means because all of these modes, as you know, they're also modes on the vent. Cpap and SIMV and AC are also modes on the same vent. So when you add the word MPPV, what's the difference? The difference is that the vent is not going to alarm when there is a lot of leak. If there's a leak, the vent is not going to alarm. All right. So this is the equivalent of this. The spontaneous time is the equivalent of the MPPV CPAP pressure support. And the spontaneous time is the workhorse. That's the most BiPAPs are. The difference here is that when you order 10 over 5 here, that's equivalent here to 15 over 5. It's a simple thing, a simple calculation, but people get confused with it for some reason. So if I have somebody who is 10 over 5, that means you have to think about what you're saying 10 over 5. The 10 is pressure support, so it has to be pressure support. And the 5 is PEEP. Okay? Over there, the 15, it's called IPAP. IPAP. And the 5 is the EPAP. Okay? So the EPAP is the end expiratory positive pressure, end expiratory pressure, and or expiratory positive airway pressure, and the IPAP is inspiratory positive airway pressure. So when it says inspiratory positive airway pressure, that means the maximum pressure during inspiration, right? It's not a pressure support, so that's why it encompasses the EPAP with it. Is this important? Looks like it's not that important, right? It is actually very important when people keep changing between BiPAP and vent. So you get confused what you're ordering, and sometimes they change without even telling you. So I'll tell you a story, 2 stories that happened years ago. Somebody who just got extubated. When somebody gets extubated and you order BiPAP, extubate to BiPAP, what do you think, what type of BiPAP they're gonna use? They're gonna use a machine BiPAP or a vent BiPAP? Of course they're gonna use the vent BiPAP because the vent is in the room. They just change the tube to a mask. And we put the patient has a lot of hypoxia, more than acidosis. So we put the patient on pressure support of 15, right? Pressure support of 15 and PEEP of 10. So what's the maximum pressure here? 25, right? 15 above the 10. Okay, maximum pressure 25. Now, when the respiratory therapist wanted the vent for somebody else and wanted to switch him to a BiPAP machine, he switched the patient to also 15 over 10. Which is, what's the maximum pressure here? 15. So the 15 is here, and the 10 is here. So what's the driving force? It's only 5. So the patient went from, driving force of 15, or driving pressure is 15, to driving pressure of 5, just because you use the same numbers and just in 2 different modes. The opposite also happened. The maximum pressure that you can give on the BiPAP is 25. You can't give more than 25. And you know where that comes from? From somebody's imagination. The 25 was found actually in animals, that it actually makes the, not in animals, I think it was in volunteers. But they found that the cricopharyngeus, which is the first muscle of the esophagus behind the larynx, can be overcome, the contraction of the cricopharyngeus can be overcome with pressures 25 or higher. So then you open the esophagus and then you start having air in the esophagus or air in the stomach. So that's why by definition you can't give BiPAP for somebody more than, the pressure more than 25. Otherwise they vomit and aspirate and stuff like that. So So the same thing happened. Patient was on BiPAP, right? And he was on 25/10 on the BiPAP. And the respiratory therapist took him off the BiPAP because he needed the BiPAP for somebody else and put him on the vent. And the vent was 25/10. What's the maximum pressure here? 25. What's the maximum pressure here? 35. So nothing happened to the patient, but not happened to both patients, but it was one of them became acidotic, the other one, we caught it before he aspirated. But this happens all the time. You gotta keep your eyes in the middle of your head. It will happen, I guarantee you. I don't know why, but math is very difficult in this country. So people, or they forget, they just forget that it's switching between one mode and another. What are the settings for the Cpap pressure support? It's basically you have the pressure support, you have the PEEP, and you have the FiO2. Very simple here on the vent. On the BiPAP, there are multiple settings now. The ST has IPAP, it has EPAP, it has actually a respiratory rate, which is unheard of. This is new in this vent. It has also eye time, which is unheard of. You have eye time for BiPAP. You hold them up, and then it has FiO2, it has Rise and Ramp. And we'll talk about the Rise and Ramp in a second. But that's all of these settings are in ST, and we'll talk about ST when we talk about the troubleshooting. Now, SIMV is the same like SIMV, right? The MPPV SIMV basically has pressure support, inspiratory pressure, right? And then it has PEEP, it has respiratory rate, it has pressure support, and it has FiO2. These are the set parameters there. So basically for MPPV SIMV, you set the PEEP, you give a pressure support, inspiratory pressure on top of it, even if the patient doesn't breathe, at the rate that you order. But also you allow that the patient breathes here, and he gets whatever pressure. So this is inspiratory pressure, and this is pressure support. See the difference between inspiratory pressure and pressure support? The wave is even different. The pressure support by definition is not wide. The inspiratory pressure has some width to it. This is the pressure control, and this is pressure support. That's the difference between pressure control and pressure support. And of course it has all the bells and whistles of SIMV, which is like when to, if the patient takes a breath close to this, then it becomes this, and reset the time. The MPPV AC, that's when you put the patient on almost like pressure control, but on the BiPAP, on the mask. And it has inspiratory pressure, it has PEEP, it has a respiratory rate, FiO2, and eye time. Okay. Now on the other side, the BiPAP modes, we have ST, we have Cpap. Cpap is only one line. Cpap reads as continuous positive airway pressure, just one number, right? And it's basically saying that we'll give the patient one number of 10 the whole time, or 12 or 15. And that's mainly used for sleep apnea patients or CHF patients. They love that. In real life, especially CHF patients, they need some movement a little bit. So they may actually, you may put them on that mode, the Cpap mode, and they don't tolerate it. So you just add a little bit of IPAP to it. Like you do IPAP and EPAP, make the EPAP high, very high, and do a little bit of difference in the IPAP. So you can do 15/10, which is like only 5 of movement of driving pressure over a 10 of, so it's almost like you're doing the Cpap that you wanted, but you're also helping the patient a little bit so he doesn't feel suffocated. Pressure control, this is the same pressure control like this one, but this, when the BiPAP becomes vent, by the way. This is how the BiPAP could be used as vent. It has a pressure control in it, but it's a weird pressure control. The pressure control doesn't have inspiratory pressure or PEEP. It has also IPAP and EPAP. So be careful, when we used that during the COVID epidemic, we had to adjust, it was a learning curve, right? because you're going to put somebody on 20/15, over there is going to be 35/15, right? Because it's IPAP, EPAP. And then, of course, it has the respiratory rate and the eye time and all the, and FI2, okay? The AVAPs, we talked about the AVAPs before. AVAPs is adjustable volume assured pressure support. Adjustable volume assured pressure support. And there's a company now in this area, the trilogy, is going crazy with AVAPs. Somebody smart invested in BiPAPs, but only AVAPs BiPAPs, right? So I even asked them if they can do Cpap. They said we don't do it. We just do AVAPs. Like the whole company is built on AVAPs. AVAPs was approved in Europe 25 years ago. And then actually it didn't make it to the United States for a long time. It was crazy. So I don't know, the FDA took a long time to approve it, and only like 10 years ago they approved AVAPs. And that's why people were waiting for it. People were actually waiting for AVAPs to come. And when it came, somebody was ready. And that move made the BiPAP much, much tolerable at home. You don't need a doctor, and really thrust the home care to amazing levels now. So the AVAPs, you know how you're supposed to have an IPAP and EPAP? Here, you remove the IPAP and exchange it with tidal volume. So tidal volume, PEEP, inspiratory pressure, rise, and respiratory rate, and FI2. Okay? So what's the tidal volume situation? Tidal volume is basically the machine is giving whatever pressure support it takes to actually, whatever pressure support it takes to actually achieve the tidal volume you want. So if you tell the machine, now I need 350 tidal volume, the machine gives the PEEP, and then you want to breathe, so the machine will give you whatever it takes, pressure-wise, up to a limit, obviously, right? 25, let's say, of pressure, to give you the area under the curve here is 300. When you get better, and you don't require all of the pressure, the machine will do this, and gives you also the 25, and find out, holy moly, wow, that's 600 tidal volume with the same pressure. So what are we gonna do? We're gonna decrease the pressure, and until it achieves 300 tidal volume. So now the pressure is 15, but the area under the curve is the same like this. So the tidal volume is the same, but achieved with a pressure of 15. And then it keeps doing that until you're like 7/5, and then an arm comes out of the machine and extubate the patient. And you don't need anything, or remove the BiPAP. This mode can be used on a vent, by the way. This mode is available to be used on the vents, but there's none of the vents, the new vents that I'm aware of, had actually included that mode. So the only way to use the AVAPs on the vent is to use it on a BiPAP machine and attach it to an endotracheal tube. But with the BiPAP patients, this is an amazing mode. This is one of the things that we say no patient cannot tolerate the BiPAP. This should disappear from the lingo, because this thing makes the patient so comfortable. COPD patients, the first day they come in sucking the air, they're making love to the BiPAP. The next day, and it'll be high pressures and everything, and they're happy with it. The next day, the same patient is ripping the BiPAP off because it's too much for him, the pressure. And we forget to titrate the pressure, and it's difficult. So then the best thing is to give him the AVAPs, and then whatever pressure they need, they get.
So this is basically like measuring dynamic compliance?
Yes, dynamic and static compliance, actually. Okay. Both. Yeah. So if you have airway obstruction, dynamic compliance, then the machine will increase the pressure. If you have static compliance issue, the machine will also increase the pressure. That's amazing, right?
Yeah.
Okay, so let's quickly talk about some troubleshooting of BiPAP. So the main thing is going to be acidosis, and then if there's time, we can talk about the other troubleshooting. But you can tell from the other, like it's easy to find out. So basically, let's say the patient is acidotic, so now it's 7.1, 100, whatever. So what's the first thing that you need to do to improve acidosis? right? We're gonna increase the iPad. So this is here. We're gonna increase this one, the iPad. We're gonna increase the driving force, and that will increase the tidal volume. Number two, you're gonna have to decrease the EPAP because they are interdependable. It's not like the PEEP and the pressure support. Here, if this is, and you reach to a max here of, like the max is 25 already, so the only thing you can do is drop this a little bit, go from 10 to 5, and then you have this reaching all the way up, so now it's much higher. Instead of having 25 over 10, you'll be like, and the driving force is 15, now you have 25 over 10 with a driving force of 20, right? So that's decreasing the EPAP. Number three, the respiratory rate, right? The respiratory rate is important, and as I said, it's something new on the BiPAP machine, so most respiratory therapists don't know what to do with the respiratory rate. Because if anybody was trained like more than 4 or 5 years ago, they will have a BiPAP machine that doesn't have a respiratory rate, because it's supposed to be like a Cpap, right? It's supposed to be like a pressure support type thing, right? So why would you have a respiratory rate there? They put the respiratory rate as a backup, so that if the patient stops breathing, you know, something is there to give him breaths. The respiratory rate, it results in a big problem, right? Because the gold respiratory rate is 4. You want a respiratory rate of 4 because you want it to be as what it was intended to be, which is just a backup. The respiratory rate on BiPAP should not be used for the most of the time. It should not be used to be the force that ventilates the patient. So why am I saying this? So basically, let's say on a vent, the respiratory therapists start to actually extrapolate from the vent and make as if the BiPAP is the same as the vent. So on the vent and on the BiPAP, what I'm describing here is going to happen. So let's say you ordered a respiratory rate of 10 on the vent, right? And the patient is breathing at 15, the patient respiratory rate, okay? What do you think what percentage of the patient's breaths are initiated by the patient? If you order 10 and the patient is breathing at 15, all of them, right? The new vents, all of them. The old vents were not. So that like 20 years ago, it wasn't. It was actually 10, stays as 10, and then the 5 is extra, right? So you only breathe up, when your maximum pressure, maximum respiratory rate or the recorded respiratory rate is 15, that means you took the 10 from the vent and you added 5, which that's what resulted historically in SIMV having what we call breath stacking. Right, that was the problem with SIMV. That's why AC won the game, and SIMV is dead now. Right, that's another lecture. But in general, new vents, new BiPAP will actually have a refractory period that will detect when you got the last breath. So if your respiratory rate is 10, that means that you have 6 seconds per breath. Right, every 6 seconds you're getting a breath, no matter if you want it or you don't want it. But if you're breathing at 15, what's going to happen is that in 4 seconds you're going to take a breath, right? That's a spontaneous breath. The machine will find this. The machine after this, it will give a 6 seconds refractory period. So the machine is not giving you any breath in 6 seconds. So it will cancel this breath and not give anything and wait until 6 seconds. If you don't take a breath, it will give you a breath. But if you are breathing regularly at 15, you're going to take another breath here. And then put the machine in refractory period again. So what ends up happening is that you're starting all the breaths, which is great, by the way, for the comfort of the patient and for decreased sedation and stuff like that. That's on the vent. On the BiPAP, same thing happened. If I order 4 and you're breathing at 30, you're putting the 4 that doesn't exist. The problem is that if you start giving patients 12 on the BiPAP, right, or 10, like some respiratory therapists put 10 or 12 as the baseline, as if they're doing the vent, as if they're putting the patient on. What ends up happening, the BiPAP patient is by definition more awake than the vent patient, right? The BiPAP patient is more awake. So by definition, he doesn't have a regular respiratory rate like the vent patient. He may want to talk. He may want to swallow. He may want to stop breathing for a little bit. He may want to adjust the BiPAP or whatever, something like this. So in this situation, if you're giving the patient 12 breaths per minute, for example, that means every 5 seconds, the machine is going to give a breath. So if I'm talking to you, the machine in 5 seconds keep on pushing in my face the BiPAP. Or if I'm swallowing, and it happened to be around the time of the machine, and the machine doesn't feel anything. It just whoop, gives you the breath. And when that happens, where do you think, if I'm swallowing, which one is open, the esophagus or the larynx? Of course, the esophagus, right? The esophagus is open, and the larynx is closed. Actually, the vocal cords are closed. So the path of least resistance is the esophagus. So as I'm talking, I get if I'm swallowing, I get a breath, and it goes all in the esophagus, and that starts a vicious circle. The belly is distended. The patient is angry, and you get more agitated and coughs against the BiPAP, and the BiPAP pushes as he coughs. When he coughs, then it goes to it goes to the esophagus, and then he vomits, and aspirate on the BiPAP, right? And becomes also, if the patient is unsuspecting, completely unsuspecting, if I'm not, just to show you that these breaths, even if even forget about the going, the breathing against or whatever. Let's say I just don't want to take the breath now. You order 12, but I want 11, for example, or something like this. So I'm just unsuspecting. I'm waiting like this. What happened? What do you think the vocal cord position is when the patient is not breathing? Like after the inhalation, exhalation, the vocal cords is in what position? Is in a closed position. So then the hope that when I give the BiPAP or the BiPAP goes, what we're hoping for really is to force the air through the vocal cord, like open the vocal cord. That doesn't make sense, because what end up happening, half the breath is going to go into the esophagus, or the cheeks will puff like this, because the patient is not ready to actually take a breath. So you lose a lot of your breath if you're not timing with the patient. So I'd rather have my patient actually initiate all the breaths. So why do we even have rate then? This, we have it as a backup, but also depending if the patient is not breathing or not. So the rule that we have here is that if the patient is breathing more than 15, then his respiratory rate has to be 4. If the patient is acidotic and breathing less than 15, then he's an idiot. Why is he breathing less than 15 when he is acidotic? Then we have to give this patient respiratory rate of 25. So there's no respiratory rate in BiPAP here other than 25 or 4. There's nothing in the middle. You can't order a respiratory rate other than these two respiratory rates on the BiPAP. Either the patient is not breathing and he's a drug overdose or something, or narcotized. I'm going to put him on 25 and do the best I can to force the thing through the vocal cords until he wakes up and breathes more than 15. Then we'll put him on 4. Or the patient is breathing more than 15 and put him on 4. Not in the middle, that make no sense. All right, number 4, eye time. So eye time, not that important here, but it only applies to the respiratory rate. So the eye time doesn't apply to all of the breaths. Initially, I thought it applies to all the breaths. I was freaking out. But the eye time applies only to the breaths that the machine gave you. So if you breathe less than 4, for example, and the machine, is saying that I have to give you 4 breaths, these 4 breaths will have that eye time that you ordered. If you're giving 25, they're all the eye time that you ordered. So I've seen respiratory therapists in other hospitals do weird things, and here sometimes, basically, mostly away from outside of here. But anyway, they start titrating the eye. When a patient is hypoxic, they start titrating the eye time higher and higher and higher, right? And it reached the point that I've seen a patient with an inverse ratio on the BiPAP. This patient didn't do well, was not tolerating the BiPAP, had to be intubated, and when I looked, it was inverse ratio. They didn't notice. So what ended up happening is that the patient they also placed the patient on 10 breaths per minute, right?
Yeah.
So now he has 6 breaths per minute. right? And then they put the inspiratory pressure, the eye time, as 3 seconds, because it's 1-to-1 for some reason, because the patient is hypoxic, but the patient was breathing at 20. So if you're breathing at 20, 3 seconds is almost all of your breath. So I don't know how the patient was breathing, but it was just breaking through, like the machine wants him to keep. I'm sorry, he put the machine. Sorry, the example that I'm giving is that he put the machine at 25 rate, and he was setting this to be inverse ratio, meaning that I think it was 1.6 seconds or 2 seconds, something like that, which is basically more than what the breath have, or close to what the breath have. 25 breaths per minute is about 2.5 seconds per breath or something like this.
But I have a question, because so if the machine is still delivering the breath and the patient's now starting to exhale, isn't the amount of leak through the mask going to increase? So
Yeah.
it should be a sign to them
Oh yeah, of course.
that the eye time is too high, because all of a sudden
Yeah, there's more
you're
leak.
having more leak.
Yeah, so what ended up happening, the machine, there's some, what do you call it? There's some protective mechanism on the, or bells and whistles on a BiPAP that actually feel as if the patient breathes against and stop the eye time. But that requires a lot of, effort from the patient, and it looks that the patient is very discoordinated and there's a lot of leak. So the patient didn't do well because we had to sedate him, or people have to sedate him very much, because he's not tolerating the BiPAP.
Right.
They don't tolerate it. The eye time. Remember when we talked about the pressure control? We said in pressure control, if you make the eye to E ratio 1-to-1, it means that the patient requires more sedation. If you inverse the eye to E ratio, the patient requires more paralysis. Right? So here on the BiPAP, you're inversing the ratio, and somebody was completely awake, not even sedated. It's crazy. So you be careful with the eye time. I always set it up at 0.7. There's no need to have eye time more than 0.7. And in fact, in patients who are acidotic, you want the eye time to be 0.7, and you want a long E time. They are COPD patients, so they want to give them the shortest eye time and the longest E time to exhale whatever they want. Now there's another thing called the Ryzen Ramp. I promised you we're going to talk about the rise and the ramp. These two things, if you adjust them correctly, you will never gonna have a patient that says, or very rarely you have a patient that says, I'm not tolerating the BiPAP. The rise and ramp. The rise is the rapidity of rise of the breath. So the breath can be given like this, or like this, or like this, and so on. This is 1, 2, 3, 4, 5. You have rise from 1 to 5. 1 is the fastest rise. It goes up, right angle. 2 is a little slanted. 3, a little bit angle, and so on. The slowest rise is 5. So if the patient is feeling like a wind tunnel in their face, just decrease the rise a little bit. So most of our patients you see on 2, 3 rise. When the COPD patient comes in, thank God, they just like a rise of 1. They want all the pressures that you have. The next day, you either switch them to AVAPs, or you decrease the rise to 2 or 3. And the AVAPs has a rise too, by the way. Now the ramp is a funny trick that we're tricking the patient, basically. We're telling the patient, let's say we want to put the patient on 25/10. So that's a lot of pressure. As soon as you put the BiPAP on the patient, and by the time you're adjusting the BiPAP, especially if the patient is anxious, that first few breaths, he's feeling what is going on here. I was minding my own business, and now, there's like a wind tunnel in my face. So they start getting agitated, and it becomes a vicious circle right away. The ramp looks like this. The ramp fools the patient basically. You want to have 25/10, right? But if you dial the ramp, you have option to dial from 0 to 45 minutes. So you're telling the machine, give me those settings that I ordered in 25 minutes or 30 minutes, right? So the machine starts with the smallest settings, like 4, and here is like 9. So 9/4, for example. And then keep increasing every minute until it reaches the setting that you want. So over time. So the patient actually receives that very well and actually tolerate it once it reaches there. Obviously, you don't have that luxury if the patient is like, hypoxic now or acidotic, very much acidotic now. But agitated patients, you can actually use the BiPAP on them and fool them into tolerating it like this. Or let's say you're giving the morphine now, and it doesn't kick in for some time, you can just do that. Now, number 6. Again, by the way, there's also a BiPAP that they use in other certain small number of hospitals that actually senses your diaphragmatic movement. Because if the patient has a swallow, if he swallows, that actually the machine receives it as a negative pressure, but it's not a negative pressure from the lung. It's a negative pressure from your. You're doing like this. The machine thinks that it needs to trigger the BiPAP. Here, in those other vents, they add an additional thing. They have an electrode over the diaphragm, and they actually feel or record the diaphragmatic movements. So when the diaphragm moves, the machine will give you the breath, which is much better, much more comfortable. But again, there's so many things that you can do for BiPAP patient. Morphine, you can actually give the patient morphine to decrease their urge to breathe. When we talked yesterday about the morphine, we said morphine for some reason gives you the one that gives you the most comfort when it comes to respiratory distress, right? The others could be very close, but traditionally morphine is the one that people use. But please, when I talk to people like this, you have to use common sense. I told somebody morphine, and they took a patient with a 7.15 pH and give him morphine so he can tolerate the BiPAP. That's not the patient you want. You want at least the pH to be above 7.25 or something, or 7.2 at least, something that the patient is not going to die. And what you're hoping for is that you're going to give the morphine, and their compliance with the BiPAP will actually result in a much better pH. But if you're going to play with the ones range, you're going to kill some people. You can't do that. Right, so how about Presidex? Presidex is a good alternative. It doesn't depress respiration. You just have to be worried about it a little bit. I worry about it a tiny bit, especially when it comes to somebody who's very hypoxic or very acidotic. Because how do a hypoxic and acidotic patient die? What's the mode of death? What's the type of cardiac arrest? Bradycardic, asystolic cardiac arrest. And we're giving something that we're giving bradycardic to start with. So, you gotta be careful. We use it a lot on BiPAP patients, but not the ones that are just like, 6.9 and he's on BiPAP. No, we're not using Presidex on this one. This is a hairy situation here. Not even morphine. All right, next. Remove the pillow. And nasal airways. So we don't think about the upper airways. Most people just ignore the upper airways. The upper airway is a factor in BiPAP. BiPAP is not a vent, guys. The BiPAP has to go through the upper airway. So if the upper airway has a problem, the majority of our patients that come to the ICU in the United States have sleep apnea, right? And we all know that they have a lot of tissue here. So when you give the BiPAP to somebody and it requires 15 of pressure or 10 of pressure just to pass through this tissue, what's left for the patient? If you have 20/5, 10 of those are just consumed in the tongue and the thing and moving things away, and then by the time it reaches, it's like a hose. By the time it reaches after that, the hose is like dribbling, right? So same thing here in the BiPAP. Always consider the upper airway. It's it's up there in the algorithm, right? So how we do that? Number one, you have to remove the pillows. Our nurses are very kind to the patients. They actually, Hotel Brachtanistan, they put like two pillows under the patient head. So the patient is like this. Show me how we gonna breathe like this. The BiPAP has to go in and the air has to hit the cribriform plate, and then go down like this. It's impossible. So you have to open the patient's airway, sniffing position, and it doesn't matter. If the patient say, my neck hurts, I'm sorry. I'm not doing this for anybody above 7.2 pH, you know what I mean? If your neck hurts, I'm sorry. You're 6.9, you are going to die. If your neck hurts, at least that's the only connection to life that you have. Until you're better, we can give you the pill. Nasal airways, you have to open the airway also. So the airway is closed here, right? And there's like the tongue is falling back and touching the back, the posterior wall. If you put a nasal airway that long enough that passes beyond the tongue, that's your be a channel for you to. So we put 2 nasal airways, and just go through, the obstruction there. But you have to use the correct size. For adult males, usually 36, and for adult females, is about 34 French, right? Number 8, basics. What? Basics for respiratory failure, blah, blah, blah. Yes, because what end up happening is these people end up also mixing their failures from from only related to COPD to also CHF. How? So these patients have cor pulmonale by themselves. The COPD patients have cor pulmonale. Then they start having respiratory failure. So now the high CO2 and low oxygen. Now the pressure inside the pulmonary circulation is so high now, and they're having even worsening of the right-sided function. Now add to that BiPAP, right? The BiPAP increases your afterload of the right ventricle, so it makes it even fail more, right? And add to that, if there is an ideologue, oxygenophobe in the ICU, where they actually want to choke you and go down on the oxygen all the way down to 30%, then you're even worsening the pulmonary hypoxic vasoconstriction, and all of those together will make the right side fail, pushes on the septum flattens, and now the left side will have diastolic dysfunction and start flashing into the lung, right? So now you have both things. So Lasix might help in this situation, especially in an acute situation where you can't do anything else, right? What else? THAM. And THAM is a buffer, right? You can't use bicarb in those patients. You can use bicarb as a bolus initially maybe, but that's not going to treat anything, because the bicarb makes CO2, and the CO2, and after you give a lot of bicarb, the CO2 and the bicarb are the same, which result in rising in both, and the pH will be the same. So if you're 7.100, this is 24. This will be 30, this will be 110, and this will be still 7.1. And then you get acidotic because you have more, then you get hypoxic because you have more CO2. So bicarb never makes you acidotic, by the way. There's a misconception that bicarb will make the COPD patient acidotic. No, it will make them have the same pH, but they'll make him hypoxic, because the PCO2 will rise, and now there's less chance or less room for oxygen in the alveoli. Right, next is, this one, you're probably going to stone me for this one. Increase the EPAP. What? We just said decrease the EPAP here. And here, number 10 in the algorithm, we say increase the EPAP. Yes, because when you increase the EPAP, you potentially, I'm not advocating to do it first, by the way. First, you decrease the EPAP. And then if everything is breaking, you can't fix the patient, increase the EPAP. Go from 5 to 8, from 5 to 10, something like this. And by doing this, you're actually opening the upper airway a little bit. You're opening the bronchoconstriction a little bit. Just forcing the alveoli, forcing the bronchi not to constrict. And that allows the inhalations to go through, all of these things. By the way, one thing that is not consistent in respiratory, by the way, you have to actually watch and do that. And I told them, but things happen sometimes, travelers, all of these things. The nebs have to go on the BiPAP. If somebody's on BiPAP and there are nebs, sometimes there's 2 different schedules. The nebs are giving every 4 hours, and sometimes it falls on the patient when he has a mask on, and they're giving him nebs. And I've seen some of them actually holding their own mouthpiece. I mean, it's like, I just lose my mind. But anyway, you know, you would put it on BiPAP. It's easier that way, you know. All right, number 11. Switch to I feel like I'm missing something. Oh yeah, the nebs and stuff like that. So let's do that first. Nebs and Solimedrol and all of these things. Take no prisoners, my friend, please. No prisoners. It's not like, okay, let me increase the neb from 2.5 to 5. Let me increase the neb to blah blah blah. And by the way, the change of the change that you do on BiPAP, you have to get the gas in an hour. There's no every 6 hours. Don't expect any change in 6 hours. If you're expecting a change in 6 hours, you're depending on the Solimedrol, not on the BiPAP. You need to change something on the vent on BiPAP. The effect of that, you'll see it in an hour. So don't fool yourself. Let's do it in 6 hours. Yeah, we did this thing and CO2 did not improve. Well, it's too early. It's 1 hour. No, your change didn't do anything. Your change only in 1 hour. After the things that work is the other things, the nebs and Solimedrol. Yeah, in 6 hours they will improve. So, but if the patient is like in big boo-boo like this, they have to be, your change have to do something. So anyway, just depend on the nebs. As I'm saying, take no prisoners. Give a lot. Give more than the patient needs, and then retract. Right? So tons of the 1 hour neb. 15 milligram of albuterol, 15 milligram of albuterol. Tons of Solimedrol. If you have to go even higher than 125 Q6 for the first dose or a couple of doses, that's fine. Yeah, theophylline, anything, just and then retract them. Just take them back, okay? And this is a whole other lecture, the bronchodilators and stuff like that. But the last thing here for the algorithm, this is in order that I do it, by the way. Yeah. So change to vent BiPAP. Why is that? So the machine BiPAP has more bells and whistles, actually. The machine BiPAP is much better for the patient, much more comfortable for the patient. So why switch for vent BiPAP? Because the vent BiPAP is the real thing. It actually has two limbs. The machine BiPAP has one limb. What's the difference? What is the expiratory port here? This one here. There's a little tiny hole here. Exhales. It used to be open to air, by the way. Since COVID and a little bit before COVID, actually, there was like they connected to like with the nasal cannula tubing kind of thing to the back of the vent or something to kind of whatever to contain the whatever is coming out of the patient. You know what I mean? There's also holes in the mask that you can forcefully breathe through it. You can also breathe outside the mask and stuff like this. But anyway, if you're exhaling like this, do you think the CO2 is a good boy and just gonna Professor Cal wants me to have this, wants me to go that way, so I'm going to go that way. Of course not. We go that way too. So now, next breath, you have CO2 from here all the way down, so all of this is a dead space. As opposed to the vent, this is inspiratory limb, this is expiratory limb, it goes like this. The next breath pushes those down, so that you can see that the dead space is much, much less in the BiPAP, on the vent BiPAP. For hypoxia, I don't want to go through it. For the troubleshooting for hypoxia and for patients who are here for recruitment is very easy. It's not the BiPAP is not essential for them, so I'm not going to go through it. But the one that I want to go through in the last 2 minutes or so is the literature on BiPAP. So obviously, you know that BiPAP has been studied in patients with COPD and patients with CHF, and that thrust the BiPAP into few years, 15 years or 20 years ago. When I was a resident, there was no BiPAP in the ICU, period. There was no BiPAP in the ICU, and when we started using BiPAP in the ICU, we used to call it the marker for intubation. Like if I'm walking in the ICU, I want to see which one I should intubate today is the one on the BiPAP, because we were using it late and stuff like that. So BiPAP was feared off, but now everybody's on BiPAP. It proved to be great and blah, 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 especially in COPD and pneumonia, right? This was actually done because they selected COPD and pneumonia. They did not compare them to something else. It's just like in a study subgroup analysis, they found, maybe those are the ones that are improving the most, but there was no head-to-head comparison and saying, let me get the pneumonia patient. Did I say COPD and pneumonia? COPD and CHF. Pneumonia by itself, nobody took pneumonia and said, BiPAP, no BiPAP. Not that I'm aware of. Pneumonia, let's randomize them to BiPAP and no BiPAP. So there is an old fear that you see repeated some of the, the bow ties. They say you can't use BiPAP on pneumonia patients because they don't do well. They are right. They don't do well as COPD patients, but you still can use it. This is all statistics. I don't want to intubate every 90 years old that comes with pneumonia because she's in respiratory failure. Some of them, 50% of them or so, they do well with the BiPAP. So why not, see? But that tells you something, that you have to have a low threshold to intubate patients with pneumonia on BiPAP. Why? Because secretions and stuff like that. How are they going to clear the secretions and stuff like that? So you have to go at low threshold. So if you tell me you can beg me the whole night to intubate that COPD patient that is acidotic on BiPAP, I'm not doing it, because with everything that we talked about, I will be able, for the most patient, 90% of the patient, I will be able to reverse it. But if I pneumonia and you say, okay, well, he has pneumonia, but he's doing worse, then chances are I'm going to intubate much earlier, right? So that's one thing. The other myth on BiPAP, people say that you can't use BiPAP with somebody who is obtunded, has no mental status. It's so prevalent. This is untrue. This is not true. This is, again, one of those things that is you have to have common sense. Somebody comes in with a drug overdose, not even drug overdose. Somebody comes in COPD exacerbation. He's already obtunded because you have a lot of CO2. The treatment is BiPAP. So you're going to prevent me from putting the BiPAP on the patient because he's not talking to me? The whole point is that how much time you're going to use the BiPAP on those patients and in what position. So they have to be 45 degrees angle. You can't do it. You can't do it for more than 4 hours or something, and then you have to make a decision, right? Whether you want to do it or not. I'll tell you a story from anesthesia that proves to you my point. So when we had LMAs introduced in anesthesia, right, we were so scared of them. LMAs, that means it sits a larynx, a mask basically that sits above the larynx and the esophagus and doesn't protect the airway. So patients can actually vomit and aspirate under that mask, right? So then we had this very strict criteria. If somebody's like me, BMI, holy moly, we can't use LMA on you. So if I'm having surgery 20 years ago, they would not use LMA. They will intubate me, because they're worried, that have a high BMI, and we're talking about like any high BMI. Okay, if you eat Mexican food and have a little bit of GERD, no BiPAP for you. If even diabetes, they said diabetic patients, we would not use the LMA on them because they have low gastric empty. Bariatric patients, all of these patients were not used BiPAP, right, initially. Now, a lot of things were proven by anesthesiologists because they don't want to intubate. So then what they do is that they actually use, they said, I don't feel like intubating the patient. Let's put an LMA, he's fine. And it turned out they're right. A lot of inventions happen from anesthesia that way. There's the push to go back to the computer room. But anyway, so we put the patients on LMA. Now we put patients, bariatric patients, LMA, flat, and they are under general anesthesia. There's somebody's working on something here, right? These patients, if anybody would aspirate, it will be those patients, right? Because they're completely flat like this, and they're completely unconscious. It's not like obtunded. They're completely unconscious. They have to be completely unconscious. And there is an LMA sitting above the larynx. Of course they would vomit. So we're hyped. It seems like we're hyping up this vomiting aspiration thing too much. Just be smart about it. Put the patient 4 hours on. If he turns around, fine. If he doesn't, intubate him. Or if he vomits, intubate him. Right. Last thing, literature about BiPAP and actually extubation to BiPAP. That actually liberalized our extubation a lot. Our extubation is much better now and much faster because we can extubate to BiPAP. This study was done on a COPD and CHF patient also, and showed that you can actually, if you extubate them directly to BiPAP, they actually do much better, and they have less re-intubation, stuff like that. And the key here, the study was one of the best studies done because it actually gave the option to the other arm of the study to use the BiPAP whenever they want. So the other arm of the study, you extubate the nasal cannula and you use BiPAP only if the patient requires. Okay? So you can use BiPAP here too, but the key here is that extubate directly to BiPAP. Don't wait until they fail. And we all know that this is the case in ICU patients because of lack of the positive pressure. You remove that positive pressure from the tube, now this becomes negative pressure, you have tons of fluid in your legs, everything comes to the lung, and the patient drowns in his fluid. So if you exchange the vent to BiPAP, a little bit of positive pressure, then you prevent that action from happening, and then you can wean them off a little bit more. Weaning BiPAP, by the way, the floors here don't take more than 15/5. Weaning BiPAP, we don't usually wean BiPAP by weaning the pressures. What I do usually, put them on high pressures initially, COPD patient, whatever. Then the next day switch them to AVAPs, right? So or decrease the pressure, but definitely you can switch them to AVAPs. And after that they go to the floor. The floor doesn't have AVAPs, so we have to do 15/5 so they can use them on the floor. And we tell them don't bother yourself by weaning this, or here also don't keep weaning the 15 or the 5 or anything. Just wean the times. So we start everybody 4 hours on, 4 hours off. There's nothing called continuous BiPAP. I know it's an option, but continuous BiPAP will actually result in crusting the secretion. In fact, our policy here, unwritten policy, is that if the patient is on continuous BiPAP for 24 hours, we'll intubate. Right? If you can't come off the BiPAP, we'll intubate. So no continuous BiPAP. You can maybe do it for the first 8 hours or something, but after that, go on the schedule 4 hours on, 4 hours off. You can wean it by saying, okay, let's do it only QHS and PRN, and then only QHS, and then only PRN, and then take him off the BiPAP. That's the way I wean BiPAP. And that's it, professors.